I'm Harsha here from Science Integra, and I welcome you all for the 12th webinar of Maha Smiles Cleft Care for Every Child. I would like to introduce you all to Miss Renu Mehta, ma'am, who is the Area Director of Smile Train India. Over to you, ma'am.
Thank you so much, Harsha. Good evening, everyone. You all may know that Smile Train is the world's largest cleft-focused NGO, and we support safe and quality cleft care for children globally, enabling them with the opportunity to live full and healthy lives. In India, we work through a network of partner hospitals. Currently, we are having 127 across India. And over 2 decades now, we have supported more than 740,000 surgeries for the children in India. Smile Train has been in collaboration with Foxy since 2019, and we are extremely grateful for this partnership. Today is another webinar in the series that we are focusing at the state of Maharashtra, Maha Smiles, Cleft Care for Every Child. Now, Maha Smiles is a CSR collaboration between Bajaj FinServe and Smile Train India to build awareness and support treatment of children in Maharashtra specifically. And through this program, we are going to enable nearly 8,000 life-transforming cleft surgeries in 3 years, which is till July of 2026. And we aim to create awareness about the importance of timely treatment and what are the timelines in cleft treatment. If you find any patients, any children who are born with cleft, parents who require help, please tell them about Smile Train. You may send them and attach them to our 11 centers in Maharashtra across 10 cities. You can also call our helpline, which is 1-800-103-8301. And without further ado, I will now hand it over to Dr. Sujit. Dr. Sujit will take today's webinar forward. So thank you everyone once again, and welcome Dr. Sujit, over to you.
Thank you, ma'am. Good evening, respected seniors, dear friends and colleagues. We are going to represent 12th ECME about cleft lip and cleft palate today. This series has been started by AMOX in collaboration with Smile Train in India to increase awareness about cleft lip and cleft palate. We are thankful to past President, respected Dr. Rajendra Singh Pardesi sir, President Dr. Kiran Kurtukuti sir, Secretary Dr. Bipin Pandit sir, and entire office bearers of AMOX for their constant support. We have 2 eminent speakers today, Dr. Krishnamurthy sir, who is going to talk on management of cleft lip and cleft palate, and Dr. Pooja Lodha ma'am, who is going to talk on prenatal diagnosis of cleft lip and cleft palate. I welcome and invite you as we are eager to listen to you. Without any delay, I request Dr. Jaya to take over for further proceedings.
Good evening, respected seniors and dear friends. So we are going to start our first session. The topic is management of cleft lip and cleft palate. We have eminent speaker, respected speaker for this, Dr. Krishnamurthy Bonathaya sir. Can I have his CV, Harsha? Yeah. So prior slide. With great honor, I would like to introduce Dr. Krishnamurthy sir. Sir is a Smile Train project director at Bhagwan Mahavir Jain Hospital. Previous slide, Harsha. Yeah. Sir is oral and maxillofacial surgeon with an experience of over 16 years. He has performed more than 45,000 cleft lip surgeries in 20 years and 8,000 plus free cleft surgeries in 10 years at Bhagwan Mahavir Jain Hospital. This is such a huge number. And then also he has done his post-graduation from Mangalore University, Royal College of Surgeons, and London and Ireland. And he has numerous research papers and publications in national and international journals. At present, he is president of Indian Society of Cleft Lip and Palate and Craniofacial Anomalies. He is vice president of International Board of Certification of Specialists in Oral and Maxillofacial Surgery. He has been president of Association of Oral and Maxillofacial Surgeons of India and editor of Journal of Maxillofacial and Oral Surgery and Journal of Cleft Lip, Palate and Craniofacial Anomalies. I welcome you, sir. And over to you, sir. without delay.
Thank you. Can I share my screen?
Yes, sir, please.
Yeah. Thank you very much for this Maha Smiles program, and Foxy from Maharashtra for asking us to do this talk on cleft lip and palate. It's a great honor and privilege. Am I audible?
Yes,
Can you
sir.
hear
Yes,
me?
sir.
Yeah.
You're
Yes,
audible.
sir.
So in the next 20 minutes or so, I'm going to try and give you a brief introduction to the various aspects of management of cleft lip and palate. You as obstetricians and gynecologists are an extremely important part of this team of caregivers for children born with cleft lip and palate, because many a times today you are the first person who finds out that a child is going to be born with a cleft of the lip and palate, and you may also be therefore the first person to break the news to the parents. So it's extremely important that you are also aware of what is going to follow in the life of this child after she is born over a period of many years. Cleft lip and palate is genotypically a very diverse group of disorders. They have identified more than 20 or 30 genetic anomalies, and the search for more goes on. And phenotypically, they also present in various forms. Some of the examples you can see here on the screen. When the failure of fusion of the maxillary and the median nasal process occurs on one side, you will get a unilateral cleft lip, like you see on the top end side. In the center, what you see is a bilateral cleft lip, and very rarely it is both sides maxillary nasal process are not fusing, or the medial nasal process may be absent. Very rarely you would get what is called as a midline cleft. You can also get clefts of the palate. They can be complete from end to end along with the cleft of the lip. They can be partial or incomplete, as we call it, and occasionally you might find the cleft that presents like what you see on the bottom of the screen, where the mucosal continuity is there. You don't see an actual break, but you see a thin translucent line or a bluish tinge to the mucosa, which indicates that there is a muscular discontinuity in the soft palate, and this is what we call as a submucous or the occult cleft. And oftentimes this is missed by experienced clinicians, particularly pediatricians who might be resuscitating the child at the time of birth, and might get then recognized only after some years when the child starts speaking and is not able to speak normally, or has what you would call as a cleft palate speech. So this is something that is commonly missed out. So you could have cleft only of the lip, as I showed you in the first set of pictures, cleft of the palate alone, or you could then have a combination of both cleft of the lip and palate. And when this happens, or it runs from anteriorly from the nose right back to the uvula on the palate, and this again can be unilateral, as you see on the left hand side, or bilateral. So like I mentioned, the phenotypically too, these are a diverse group of disorders, and they come in varying degrees of severity as well as presentation. Now, the statistics tell us that in India currently, there may be about 35,000 children being born with one of these deformities or facial differences, and approximately it is recorded to occur 1 in 700 live births. Now, before we go into the salient features of management of the cleft lip and palate, what is of importance, a common domain between you people and us would be antenatal counseling, particularly when you have done an anomaly scan and you find out that the fetus has a cleft or lip or palate. And there has been a significant amount of literature which has looked at the various aspects of counseling the mother and the dad, of course, when you have done your anomaly scan and have diagnosed a cleft of the lip and or palate in the growing fetus. There are, as you can see, a number of factors which weighs heavily in favor of this antenatal counseling, which includes psychological preparation, education of the parent. It allows them to plan the care, particularly as after the child is born, for feeding, and then various other practical issues like verification of insurance coverage, etc. And also, if they so decide, it also gives them an option of terminating the pregnancy. And on the con side, this is something that we have to be very much aware of, that you are now making the parent anxious, because now they know that there is some bad news coming. This is a study that came out of the US, which looked at 30 years of prenatal cleft diagnosis, Arun Gosain from the US. And they found out that these are the advantages of doing a good antenatal counseling to the parents, that we can educate them, we can prepare them. And then it also led to high degrees of satisfaction with multidisciplinary care. And when this paper was written a few years ago, termination of pregnancy for just isolated clefting, where there were no other anomalies present, appeared to be very uncommon event in the United States and elsewhere throughout the world. There may be some regional variations to this, but when we diagnose an isolated, standalone, non-syndromic cleft of the lip and or palate, the rates of termination are extremely low, for the simple reason that this is a problem that can be taken care of, making the child lead a more or less normal life as all other children might. Now, there's another study which once again came out many years ago in the plastic and reconstructive surgery, where they compared groups of parents that did receive antenatal counseling versus those who did not. And 1/3 of the parents thought that they had not got adequate information from their obstetrician and or ultrasonographer. And all those people who had a prenatal contact with the cleft team felt it was valuable. This is a very important thing, because oftentimes if you as the medical ultrasonologist, is fetal medicine specialist, are not well informed or not aware of what is in store for the parents and the child, you may not be able to in a clear way define the problem and the solutions when you are the first person breaking the news. So it's from our point of view, I think it's extremely important that that once the diagnosis is made, the parents get good counseling and they take whatever decisions regarding this child based fully on information that they have understood. So some of the things that we would do once this diagnosis is made is to look for other congenital malformations. I don't need to tell you about this, but most important thing that we would like you to do is to be reassuring and discuss the diagnosis, and to briefly tell them what happens when this child is born, what is the pathway that is in store for this child, but without overwhelming the patients with detail. And most importantly, this is something that we've already seen from the preceding literature, that when the parents have contact with somebody in the cleft care team with whom they discuss the future of this child, it leads to better outcomes. So therefore, once a diagnosis is made, once you have done your preliminary counseling, that you brief the parents, it would be a very, very important thing that if you could refer these parents at this point of time to some members of the cleft care team. So now let us look at very, very briefly an overview of what happens when a child with a cleft lip and or palate is born. The problems that the child might have will depending upon the type of presentation, but this is an overview. One of the important things that we need to be aware as soon as the child is born is to make sure that the airway is okay, And the second important, and once you know that the airway is all right, the next important thing is to establish feeding. Feeding could be a problem in these children, particularly when they have a cleft of the palate. We'll discuss that in a little bit greater detail. What is going to be a simple matter of latching on to the mother's breast, an uneventful thing, is not going to happen in the way it happens for other children, and it can give rise to significant problems. So these are the two important areas of priority as soon as this child is born. And if we have done antenatal counseling, the parents are aware of what might happen. Once again, it is important to look for various other congenital malformations, and like I specifically mentioned, a submucous cleft palate which may be missed out. And obviously there'll be psychological support that will be given. So why do we get this problem of airway obstruction once in a while in these children? This particularly happens not because of the cleft palate, but it happens because of the associated micrognathia or retrognathia, where the mandible is placed significantly backwards as a part of a syndromic complex or a sequential complex, which includes cleft palate as well. The common condition is what is called as the Pierre-Robin sequence, or the PRS, where in addition to the cleft palate, the child will also have a significant amount of retrognathia or posterior positioning of the mandible, which makes the upper airway extremely narrow to such an extent that the patient might have difficulty breathing, might come with stridor, or with signs of upper airway obstruction. And in severe cases, it can lead to severe hypoxia and death. So therefore, if we find this kind of a situation that's happening in a baby with significant retrognathia, as you can see in this patient, a number of things that may be required depending upon the step ladder of the management, depending upon how severe the situation is, starting with simple conservative measures like prone positioning of the child. When this does not work, a nasopharyngeal airway may be used, a nasal CPAP may be used, but if this is not relieving the obstruction, the child might need an endotracheal intubation, or rarely might require tracheostomy straight away. But if conservative measures fail, surgical management is something that we need to do. There are two different surgical procedures that can be done in an infant to improve the upper airway. One of them is called the tongue lip adhesion. The other one today that is being often done is advancing this mandible forwards, the retrognathic mandible forwards, by a process known as distraction osteogenesis. But in most instances in our practice, conservative measures usually work. Positioning, semi-prone or prone, use of nasopharyngeal airways, usually in most instances relieve this obstruction. It is just a matter of tiding over the crisis, because as the child grows up, in a few months' time, the airway opens up enough for her to be able to breathe without any props. But as I mentioned, in some rare or infrequent occasions, it might require a surgical airway creation or a surgical procedure to relieve this airway obstruction. Feeding is something that is always a problem. Here you see an example of a child that we saw about 2 months after birth, with the weight of the child being about 500 grams less than what it was at birth, significantly malnourished. And all we have done over a period from September to February for the child to become nice and chubby is to show the mother how to feed the child. So this is something that can make a world of difference over time. It is extremely important that we do not get into a situation where the child has already become malnourished when you first see the child. It's extremely important for the team that is delivering the child to be able to make sure that the mother can feed the child properly. Now, this kind of a problem may not occur when the child has only cleft of the lip. Breastfeeding is possible and is effective when the child has just the cleft of the lip. The problem arises when it involves a palate. When there is a palate, and the baby tries to cleft palate, when the baby tries to do breastfeeding, is not able to develop a negative pressure or suction because there is a big hole connecting the mouth to the nose, and therefore they find it that they're not able to get milk from the mother's breast. And even if they are able to do it, it will take them a long time. They will tire quickly. They sometimes spend more energy in trying to get a little bit of milk than what milk they get in to their stomach. They will swallow excessive hair, and they may have a non-rhythmic suck. So goals here is to promote breastfeeding, to show techniques that might result in good breastfeeding. But when that is not possible, the alternative will be to feed breast milk. In other words, the most common strategy that we employ in children who are born with the cleft of the palate is to ask the mother to express and then feed this breast milk. We know all the benefits of the breast milk, and even in this situation, they are encouraged to allow the child to latch on to the breast 2 or 3 times a day for the obvious advantages of the emotional bonding that it provides for the mother and child, as well as the stimulation of lactation, because oftentimes when expressed breast milk is given, the breast can dry off quickly, resulting in insufficient amount of milk for the child. So when breastfeeding is not possible, expressed breast milk feeding, topping up with formula feeds or milk, cow's milk, etc., being the option in this situation. We also encourage the mother to latch on so that they develop an emotional bonding. One of the important things that we have to remember in feeding is the position of the child. It should not be supine. It's usually at about a 45-degree angle. The child is held, as you can see in this picture. And once you have expressed breast milk, or you're providing cow's milk, how do you feed that? There are a number of options. Simple thing is just using a spoon or a palada or a cup. These are which are very effective, which are very resource non-intensive, as well as easy to use. However, you could use specialized bottles, but when we use that, it is important to remember that strict hygiene has to be maintained. Otherwise, you might end up in the child developing GI infections often. Now, once we have looked at these critical events, have tided over this, have made sure that the child's vitals are stable, his airway is good, and we have established a good feeding pattern, and the child continues to thrive and grow, there are various other things that come into the specific management of cleft lip and palate. The first one is nasoalveolar molding. This is a procedure that we carry out as early as starting first 7 to 10 days after the baby is born, in order to reduce the severity of the original cleft deformity, as I will show you in a minute, and therefore get much better results when we do the surgery. This is something a lot of our colleagues are not aware of. Oftentimes, we have children coming in at 2 or 3 months after birth, because the initial primary care physician, the pediatrician, or the obstetrician has told them that surgery will be done only after 3-4 months. You don't have to worry now. And then when they come in late like that, we lose the opportunity to carry out this very important procedure, what we call as a pre-surgical infant orthopedics or nasoalveolar molding. You can see some pictures here. It's basically something that is carried out by the orthodontist in our team, whether it is a unilateral or a bilateral deformity. It tends to reduce the deformity by altering the position, particularly of the bone within the mouth, which is the gums or the alveolus, as well as the nasal cartilages, so that we are able to reduce the severity of the deformity, restore a significant degree of normalcy to the nose and the alveolus even before we did the surgical procedure, and the results that are obtained as a result are much more stable and better as compared to if it was not carried out. Here is an example of before and after of a unilateral cleft lip. You can see how the collapsed nose on the left side with the alveolus widely separated has altered to a nasal architecture, which looks more or less similar on the non-cleft side also in terms of the height of the lower lateral cartilages, the columella length, etc. And the alveolus also has come together. So the bony base is brought into a better position. The nasal cartilages are molded in such a way that you have more normalcy. But the critical thing is this has to be started early. The latest that we can start and succeed in this maneuver is when the child is about 5 to 6 weeks of age. Ideal time to start is a week to 10 days. And therefore, it is extremely important that when you see a child being born with a cleft lip and palate, that you refer them to a nearest cleft care center as early as possible. Here is an example of a child that has undergone nasoalveolar molding. The center picture showing after molding, and the one on the right side after surgery. You can find that the nasal architecture is quite symmetrical. And here is a child when she was born after nasoalveolar molding in the center, and 6 years later growing up nicely with very little signs of the deformity having been present. This is also important in bilateral clefts, where often we find that the central portion of the face, the prolabium and the premaxilla, jutting out with, as you can see on the left hand side of the picture, complete absence of the columella. So we are able to reposition both the nose and the alveolus to much normal situations, reducing the severity of this deformity, as you see in the center picture, and getting results as you see in these pictures. So overall, let's briefly look at the protocol. Now, this is something which is a very significant aspect of management of cleft lip and palate. It starts from the time you are doing your antenatal counseling after your ultrasound scan, anomaly scan, till the child is born and grows up to be an adult. A number of things have to be done. Some of the things I've already discussed. After birth, establish feeding, do pre-surgical infant orthopedics. We do the lip surgery between 3 to 6 months of age, the palate surgery from 9 to 12 or 18 months of age. You also need to do an ENT assessment to rule out a middle ear effusion at this time. And once the palate is repaired, the significant thing from 2.5 years, 3 years to 5 years is to start assessing language development for this child, speech assessment for this child. A number of these children require speech therapy. They may not spontaneously speak normally even after cleft palates are repaired. And in about 10 to 15% of the patients, the functional aspects of the cleft palate may not be 100%. In other words, even though it's been repaired, even though it's functioning, it's not up to the mark. It's not 100%. This condition, what we call as a velopharyngeal dysfunction or a velopharyngeal insufficiency, might then require a second surgery and speech therapy to be followed in order to make sure that the child can speak normally. We also, in complete clefts, have a defect in the gum or the alveolus where the bone is missing. And at between 7 to 11 years of age, you need to open up this cleft and put in some bone so that the second set of teeth, your permanent dentition, the particular tooth that has to come into its place in this area of the cleft can come into its place. And then you may need to then do orthodontic treatment of braces to make sure that the teeth are all aligned properly. And then from time to time, they might require some secondary corrections. Whatever primary surgeries have been done because the deformity was severe or whatever else has not given the desired result, and you may need to do a secondary correction of the lip or the nose or the palate. And oftentimes, because a number of these interventions have been carried out very early on in life, the face may not grow properly, and at the end of growth, they might require jaw surgeries to correct the deformities in their jaw. So this is a busy slide that shows the whole protocol, surgical as well as other adjunctive therapies that the child will require once she is born, starting, as I mentioned, with the pre-surgical infant orthopedics right after birth, primary surgery, speech therapy, VPD surgery if required, alveolar bone grafting, and so on. This is just a pictorial representation of what I explained just now. Just to finish off with this overview, some examples of how children with various deformities of the cleft lip and palate can be taken care of, and they can grow up to not only look normal but function normally. Let's see if this is. So that is a normally functioning palate. It's a video fluoroscopy that shows us how well the palate is functioning and the speech is normal. And when this is abnormal, that is when we'll have to do a pilopharyngeal dysfunction correction or a surgery. Oftentimes, the teeth don't grow well, the jaw doesn't grow well, and you might need secondary surgeries to correct these deformities. In these situations, the orthodontists come in and put on the braces, as you can see here, to make sure that the teeth are aligned. And finally, you can have a whole lot of happy faces that have grown up to be normal, productive human beings like all of us. Thank you very much.
Thank you so much, sir. It was such an elaborative talk, sir. You made every little thing so clear. I have one question, sir.
Yeah.
This nasoalveolar mold, or what is that? Modified
Nasoalveolar molding. Yeah.
Molding.
Yeah.
Sir, for how much time, we have to keep it? Once
so this applies.
The difference was so much significant correction.
Yeah, you're right. So it's a very, very important question. Once this appliance is put on, like I said, on the 10th day or 7th day of life, the goal is to keep it on for 24 hours a day. Okay. Except for the mother is taught to remove it, clean it, etc. But otherwise, it's for the whole day, and it takes about 2.5 to 3 months. There is an initial period of adjustment that both the child and the parents will have to go through, because this is a lot of hardware coming into the mouth and the nose. But we find that if we educate them properly, show them the results like I showed you here, what would happen if we did not do it and what would be the benefit of it. Most of the parents understand that, and then once they are motivated and they are on board, they are able to take care of these children well. But it can be a bit of a problem. It's like wearing a shoe that is pinching you. You know, it can hurt the child, and it might take 3 or 4 days before the child gets used to it.
Yeah. Sir, does it causes some nasal blockage or something?
No, it does not. It does not cause nasal blockages. The only issue sometimes is that if the pressure is too much, it can cause some slight damage. But what the orthodontist tends to do is they do a regular follow-up. Initially, it's once in 2 weeks and then once a month. So they will make sure that the pressure that is being applied is optimum and not more. And then the desired effects are happening.
Yeah. Thank you so much, sir.
Thank you.
It was a very wonderful session. So moving on to another one, Harsha. So we have next talk on prenatal diagnosis of cleft lip and cleft palate. We have respected speaker Dr. Pooja Lodha, ma'am. Can I have a CV? Yeah. So with great privilege, I would like to introduce ma'am. She's director at Kangaroo Cradle, the Fetal Care Clinic, State of Art Fetal Medicine, Pune. She is lead consultant, Fetal Medicine and Fetal Therapy, P Hall Clinic and Bharati Vidyapit Medical College and University, Pune. She is university recognized trainer and thesis guide for 1-year fellowship in maternal-fetal medicine, Bharati Vidyapit Medical College and University, Pune, and she has many awards to her academic credit, like Foxy Rajat Rai Imaging Science Award, Fox Dr. Kamath Award for Best Paper, Indian Medical Association Young Achievers Award, and many such awards. And she has been international faculty at keynote speaker at AOFOG World Congress, Korea 2024, at Maternal Fetal Medicine Congress in US, Singapore 2023, at Dhaka World Fetal Medicine Congress 2022 and 18, and invited faculty at World Congress and Donald School of Ultrasound, Dubai Convention Center 2017. I welcome you, ma'am.
Thank you so much, Dr. Jaya. Yeah, could I share my screen, please?
Yes, ma'am, please.
Is the slide visible? Am I audible?
Nicely visible, yeah, both.
Thank you so much for the kind introduction, Jaya Madam. At the outset, I'd like to thank this collaboration between Smile Train and EMOGS. And this is a really, really wonderful initiative. We'll talk about it as we go. And as the chairperson of Fetal Medicine Committee, EMOGS, I'm very glad that we are touching upon points like cleft lip and palate, which have really been ignored for a lot of time, at least before last decade. Now, prenatal diagnosis of cleft lip and palate seems to be a very straightforward topic and talk. The tricky thing here was that the delegates and the listeners is a mix of obstetricians, geneticists, we have radiologists, I have some fetal medicine friends who've joined. But the aim is not actually to how to scan a baby and diagnose cleft lip and palate, but an approach, what can be diagnosed, what can be missed, why is it missed, can we do something to improve it? Once diagnosed, what do we do? And what is the further workup required? And what help can we take from various organizations? So at the outset, thank you so much, EMOGS, for the opportunity, President Kiran sir. In fact, I'm privileged to be one of the core task persons for this collaboration between EMOGS and Smile Train, and this was when Dr. Nandita Palshetkar Madam was the president, and we have formulated an antenatal diagnosis protocol for cleft lip and palate, which is now into circulation. So at the outset, I'd like to tell all the obstetricians who are listening to this webinar right now that Smile Train is doing humongous work. We've just heard the numbers from Renu Madam, and they are doing an amazing job. Of course, along with Dr. Krishnamurthy sir and the whole team there, this is the helpline, and it doesn't hurt really to take a print and put it in your OPD. Just like we have various algorithms, doses of eclampsia, Pritchard regimen, so on and so forth, just put in this helpline because it becomes handy. As soon as you get a report from your radiologist saying that there could be a cleft lip or there is a cleft lip palate, rather than we doing all the job of counseling on behalf of a geneticist, an oromaxillary surgeon, a speech therapist, let's connect the couple to the right resources so that the decision making is enhanced. That's the main aim of my talk today, rather than going into the technical details. We will run through the technical details also, but I'll come back to this slide in the end again, where we would go through an approach of how an obstetrician should handle a report that has reported a cleft lip and or a cleft palate. So facial clefts, 50% of them are cleft lip and palate both, 25% are cleft lips and 25% are cleft palates. Now, a slightly different situation in India because as compared to the Western world, we have high degree of consanguinity, increasing the risk of the fetus to a facial cleft. There is folic acid deficiency, the socioeconomic strata we know, there are differences in India more than there are in West. And 1 in 700 live births come up with a cleft lip and or a cleft palate, which is as much as a Down syndrome. So we do so much about NT scan and double marker and NIPT and amniocentesis and everything that's come up now. We should also, with equal aggression, in fact more, work towards diagnosis of cleft lip and palate. We are pretty good at the diagnosis of cleft lip, but still lagging behind for the diagnosis of cleft palate, and especially the isolated cleft palate. Why so? When we do so much about a non-correctable problem like Down syndrome, we should definitely do a lot to diagnose a correctable problem like a cleft lip and palate, because like Dr. Krishnamurthy just brought about, that first slide was really nice, sir, where he put in the pros and cons of an antenatal diagnosis of a cleft lip palate. And we saw that the advantages were way more than the disadvantages. Well, yes, there is anxiety when you counsel a couple about a facial cleft, but believe me, a facial cleft is something that hits the eye of the couple as soon as the baby is born. It's not like a small VSD where, you know, it could close up on its own. It's not seen when the baby is born. So when a couple having an uneventful antenatal period looks forward to news from the nurse or the obstetrician that the baby's cried well and the baby is born and the mother is fine, and suddenly the baby comes up with this cleft on the face, And it's something that's not very well received in the first go because it is visually very disturbing. So it's much better for this couple to be prepared, even if it creates anxiety, the way you give communication, the way you give information to the couple, by not scaring them away, but telling them that this is important information and it is only to prepare you through your pregnancy and after birth that we are telling you this, because if eventually the couple will have to face the situation. So 75% of the clefts are unilateral, 25% are bilateral. Okay, so these are complicated diagrams and I'm not going to run through them, but it's not very simple. Like, it's not just a cleft lip, a cleft palate, unilateral, bilateral, medial. There are varied phenotypical and genotypical presentations of a facial cleft. Now, many studies and robust literature now quotes that the prenatal diagnosis of cleft palate and isolated cleft palate is extremely low. It's less than 5%. So we are more often than not likely to miss an isolated cleft palate. I take this opportunity here to appeal to our obstetric friends that when a baby is born without a cleft lip but an isolated cleft palate, the knee-jerk reaction need not be, oh, how was this missed? Because the first reaction we give, the parents carry it with them. So the first reaction probably could be that yes, the diagnosis of cleft lip is relatively easier, and the diagnosis of an associated cleft palate with cleft lip is much more easier than one with an isolated cleft palate. The good news is that we have excellent surgeries available, like we just heard. So rather than going back on how it was missed, because I will soon take you through why and how it is missed, we do have excellent surgeries and we should look ahead and help them in connecting to multidisciplinary approach and the smile train just through one helpline number, and they will do the needful. So there is no satisfactory ultrasound indicator of a direct isolated cleft palate. And that's the reason why it's very easily missed even in the best hands. Now, as early as the early 19th century, Brophy et al. Actually drew these diagrams which showed that it's not a very simple diagnosis of cleft lip, palate, unilateral and bilateral, which is why a very simplified classification is required if we all need to be on the same page. By we all, I mean the person who is diagnosing, so the fetal medicine specialist or the radiologist, the obstetrician, the pediatric surgeon, the oromaxillary facial surgeon. So we all need to be on the same page when we talk about the nomenclature of a cleft lip and palate, and for which we need to follow a very particular algorithmic approach. Now, the Kernahan's classification is the most simple, pictorial and widely accepted, and it is easy. As you see, a Y is drawn numbered from 1 to 9. Those who scan and those who are listening right now would know that on the right I have labeled from 1 to 9 how you look at things. So when you're looking at the right lip, it's 1. If it is normal, you let it be white. If it is affected, you shade it. So that's how the whole nomenclature goes. And the structures that need to be assessed in a facial cleft are the right lip, the right alveolus in continuity, the right premaxilla, going on to the left side, the left lip, left alveolus and the left premaxilla. Then you go back on the hard palate, go back till the soft palate and the submucous cleft. Now, once you have assessed all of this, you then mark on this Y of the parts that are affected. Now, once this pictorial representation reaches our oromaxillary facial surgeons, it's much easier for them to delineate the treatment plan, the number of settings of surgeries, how long will it take to correct, will it be completely correctable, how much is it going to affect the feeding and the speech. So the whole counseling postnatally can be enhanced antenatally itself if this simple pictorial graph is used by those who are scanning. Now, coming back to how to diagnose a cleft lip and palate, As usual, for a lot of more things, we don't have real good Indian guidelines for anomaly scans, and we still largely follow the ISWA guidelines. This is the International Society for Ultrasound in Obstetrics and Gynecology. And very surprising, but the ISWA guidelines do not really emphasize on the diagnosis of facial clefts. In fact, assessment of cleft palate is not even a part of the regular anomaly scan according to the ISWA guidelines. What they mention about the cleft lip is that minimal evaluation of the fetal face should include an attempt to visualize the upper lip for possible cleft anomaly. So, if you assess the upper lip in the nose-chin view, we will come to this, you will rule out a cleft lip, and this is what the ISWA basic guidelines tell us. They do not tell us to dwell deeper into cleft palate. A word of mention here that medico-legally, all of us who are scanning are really not at risk if we do not diagnose an isolated cleft palate, or for that matter, even a small associated cleft palate along with a cleft lip. Does that mean we do not need to diagnose a cleft palate? Let's see. So, cleft palate is not a part of the minimal evaluation of the fetal face presently, but with improving training, better machines, and we are trying to diagnose everything really early on in pregnancy rather than in the second and third trimesters. We do have some very simple and excellent methods where at least a suspicion could be brought about as early as anomaly scan, even on the cleft palate and not just the cleft lip. So this is the view on the left, which is the plane 18, which is known as the nose-chin view. You can see the two nostrils there, the upper lip, which is the Cupid sign. There's the lower lip, and you see the chin there. So this is a coronal view, which is a compulsory view by the ISWA, and you have to see this. And if there is an integrity maintained in the upper and lower lip, then you are ruling out a cleft lip. A hint that you can get is also on the mid sagittal view, which is the plane 20 on the right side, where if you see a smooth side profile of the fetus, it essentially rules out a large bilateral or a median cleft of the fetus. We will come to that as we talk ahead. So this is a picture I've put up only because the obstetricians, those who are not scanning, will be at the receiving end of the reports. And like I tell you, for NT, for Dopplers, make a habit to look at the images that you have received. And this should be one of the images in the anomaly scan report of the patient that the patient is carrying with the printed report. So these are the nasal wings, the nostril, the upper lip integrity. Observe the amount of amniotic fluid between the upper lip and the lower lip. And remember that a good amount of amniotic fluid is extremely essential for a good assessment of the fetal lip. This is the baby yawning. Now, I've put this up because there are various artifacts that could come up for diagnosis of facial cleft, especially cleft lip. For example, if there is an umbilical cord across the face of the baby, it could appear as a break in the continuity, and you could label it as a cleft lip falsely. There could be a hand, the baby could be facing the placenta, the baby could be lying upside down, there could be reduced amniotic fluid. The Indian collagen tissue is such that it does not give very good tissue penetration for the ultrasound waves. And even for a low BMI lady, there could be really poor views of the fetal anatomy, and these could be the hindrance factors for either over-diagnosing, I mean falsely diagnosing a cleft lip, or missing out on a cleft lip diagnosis. So make sure that there is some amount of amniotic fluid between the upper lip and the lower lip before you label this as a normal or a cleft lip. So yeah, this is what we meant here. So here we see, as in contrast to the previous images, that there is a break in the continuity of the upper lip there, and there are various levels. There's one in the midline, one on the paramedian side, one bilaterally. So these are various manifestations of cleft lip that you see on ultrasound in the simple nose chin view. This is a this is an image where the baby is kind of kissing the screen on ultrasound, and therefore you see coronally the Cupid bow sign, where you see the philtrum in the center. You see the peaks of the bow, which is actually the upper lip, very beautifully formed without any loss of integrity. And that's what you call the Cupid's bow. So when you look at this image, you have practically ruled out a cleft lip. Now, various types, we look at the typical clefts right now, because these happen along the lines of fusion. There could be a one-sided or a unilateral cleft lip. There could be a median or a central cleft lip, and there could be a bilateral or the paramedian, the bilateral paramedian cleft lips. It could sometimes be difficult to label the median and bilateral. We'll come to that. So what do you see in a unilateral cleft lip? Now, in a unilateral cleft lip, you see, as you see here on the yellow arrow, that there is a break in continuity. There is an hypoechoic and anechoic area on the upper lip, and that is the cleft. You put in color, you make sure there is no cord, you move the baby around to make sure that the limbs and any artifact does not come between you and the baby's lips, and then you ensure that you label this as a unilateral cleft lip. So this is a lateral defect partitioning the soft tissue into two. As you can see, the upper lip is now divided into two parts because of this cleft. You can clearly see that there is an asymmetry of the nose. If you just observe the figure on the right side, there is asymmetry. So the part of the nostril of the cleft has actually dipped down into the defect, and this is known as the dropping nose sign or the nose falling sign. So you see that the nostril just above the defect actually does not have support of the upper lip, and therefore it drops down, and this is known as the nose falling sign. So these are subtle hints that you can get, especially when the views are not great, that if you see an asymmetry in the nose, or you see that the nostrils are not at the same level, look harder, look further to see if there is a cleft that is actually dropping down the nose on that side, giving it that kind of an appearance. Now, because again there is no supportive upper lip tissue in the cleft area, there is a stretching of the LNAZ, as you can see here on the right side. It's a broader base of the nose there. So unilateral cleft lip involving the philtrum can be the central it's kind of the central cleft that involves the philtrum, and you can actually label it as unilateral cleft lip involving the philtrum, because the genetics of an isolated simple unilateral cleft lip is very different from the one where the philtrum is involved. So using such nomenclatures will help our genetic colleagues in their counseling to this couple. Now, coming to the bilateral, as you see on the side profile here, it's very obvious that you see a mass protruding above the upper lip. Okay, so the diagnosis of bilateral cleft lip is relatively easier on the side profile as compared to the nose chin view, where you could really miss if the views are not great. So the upper lip soft tissue, because of two clefts, bilateral clefts, is now divided into three soft tissue parts. The excess soft tissue mucosa under the nostrils is seen in the side view. Here, as we see in the lower figure, this is an excess tissue and appears as a premaxillary protrusion in the mid-sagittal section. So two clefts on either side of the median process is how this bilateral cleft lip appears. Now, the difference between bilateral cleft lip versus a median cleft lip. What happens in a bilateral cleft lip is that the median process is present, whereas because of the failure of fusion of the typical lines, paramedially there is a bilateral cleft and the central part is protruding. On the other side, on a median cleft lip, which is actually the central cleft lip, there is only a single large central cleft where there is no median process, and in the area of the median process, you see that there is a lacunae. How does it appear on ultrasound? The first image is the one that we've seen before as well. This is a bilateral cleft lip where there is a protruding median process that comes out in the premaxillary area. Whereas in the median cleft lip, you see that this area is actually pressed down because of the absence of the median process. So this is the difference between the median cleft lip and the bilateral cleft lip. Now, is there a need for extended facial sonogram? So is it enough that you've diagnosed a cleft lip? Because we saw that legally, and as the guidelines tell us, we really don't need to dwell further and try to find out if the baby has an isolated cleft palate if the lip is normal. So don't the basic views suffice? They don't actually, because we just went through the basic views and it will not allow us for the assessment of the palate. We'll come to that soon. Can we get better detection rates of cleft palate, and do we need to diagnose a cleft palate? Now, Dr. Krishnamurthy sir and our genetic colleagues would agree that isolated cleft lip has an excellent prognosis as compared to an cleft lip and palate. The genetics are different, the treatment plans are different, and therefore, yes, there is a need to diagnose a cleft palate. In fact, cleft lip sometimes is just the tip of an iceberg, and when you dwell further, you realize that there's actually a larger cleft palate sitting behind there. So once a cleft lip is detected, an extended evaluation of the fetal face is vital to diagnose cleft palate, and in fact, even the extent of the cleft palate. It's important to diagnose, it's important to have an extended facial evaluation, especially in a lady who's got a previous child with a cleft or a family history of cleft lip and palate. So either of the parents has a cleft lip or palate, because the recurrence risk is a major concern. Now, something very tricky here is that if the previous child has a cleft lip, or if one of the parents has cleft lip, you have to look harder for isolated cleft palates as well. So this could be a very tricky situation. Now, because of the premaxillar shadowing, it's very difficult to assess the palate in the second trimester. Those of you who scan would agree. And therefore, it's So an extremely proud moment for us as Indians that Dr. Lakshmi, we all know, who's done extensive work in cleft lip and palate, has come out with this very simple reproducible sign which can be seen as early as the first trimester, which is known as the superimposed line sign. It's a novel marker for the early diagnosis of secondary cleft palate, especially in cases where there is a normal lip in the fetus. So here what she has actually demonstrated, so this is a mid-sagittal view. This works best in the late first trimester. Now, our range for doing an NT scan, as we know, is between 11 to 13 weeks and 6 days. We've moved from doing an NT scan at 11 weeks to around 12 and a half weeks. But as we go further and as we are diagnosing or suspecting anomalies earlier in pregnancy, we are trying to do the NT scans between 12 and a half and 13 weeks. Number one, because we've gotten better at Down syndrome screening. Number two, because we have machines that can actually do an early anomaly scan as early as 13 weeks, and we don't need to wait till 20 weeks. The ossification of the palate, although the fusion has taken place at 8 to 9 and 9 to 10 weeks, the ossification and the visualization will not be possible at 11 to 12 weeks. And scanning this lady, especially those at a higher risk of clefts, at 13 weeks would be an advantage. So for all those who've got a family history of clefts or who are taking antiepileptics, have been on harmful drugs, teratogenic drugs, it's a good idea to do an NT scan at 13 weeks rather than at 11 for the ease of picking up defects and especially the clefts. Now this blue line here is the premaxilla. Behind that is the secondary palate, and the line above is the nasal septum or the vomer. Now so you see two lines here which are not superimposing on each other, and that is because you are seeing the vomer above and you are seeing a proper secondary palate below. In case there is a cleft, you will not be able to see the lower part of the line, and you will only be seeing it as one line as you see on the right side. So this is a very subtle sign that has come up, and it's becoming increasingly reproducible. Of course, the right side here, the baby also has a cleft lip, so it was much easier. But when we look at the line there is no superimposed line, that two ones that you can see separately. You cannot see the vomer and the secondary palate separately because there is a cleft in the secondary palate here on the right side. Now, once there has been a diagnosis of either a cleft lip and or a palate, what do you do next? You refer it to a fetal medicine unit, because like for most other anomalies, extremely important is to document whether the defect is isolated or associated. The moment there are associated problems with a cleft, with a facial cleft, whether it be a simple ventricular septal defect or a ventriculomegaly, anything else associated with one marker in the baby will completely take a different turn of events and can really affect the decision making. So calling a defect isolated, like I always say, is an extremely difficult job. And that's when you need to have a reference to a fetal medicine unit where the rest of the baby is going to be looked at in details. You have to take a thorough family history of any clefts in the family, any genetic syndromes or associations that you can look for. Are there any associated anomalies in the fetus today? If not, do mention a caveat, a disclaimer about evolving anomalies. Once you see a defect, you have to red flag this baby for anything that may come up even later in pregnancy or postnatally. Do you offer an invasive testing? You offer an invasive testing. You don't go and recommend or force an invasive testing. For example, if there is an isolated unilateral cleft lip, you can put in a word that yes, if you want to confirm that the baby is chromosomally normal, and if you want to go ahead, then you should, as a part of the protocol, go ahead and do an amniocentesis so that we are sure about the genetic part of the baby, and then we can focus on the structural and the corrective aspects of the baby. So most couples who choose to continue isolated unilateral clefts will opt for an invasive testing, because before going ahead, they want to be sure whether the baby is chromosomally normal or not. So risks for chromosomal problems are the highest with medial cleft palate, followed by bilateral cleft lip and palate, and the risk is minimal for unilateral cleft lip, because of which I told you we need to offer an invasive testing and not recommend it. Now, what do you order on amniocentesis? You don't do just a fish. You do a high resolution microarray, and this is because there are in less than 5%, but there are associated microdeletions and duplications that could be associated with cleft lip and palate, and the recurrence risk will depend on what you diagnose on this amniocentesis. So therefore, when you order an amniocentesis for a fetus with a cleft, in fact, for any structural deviation, please make sure we don't just order a fish or a karyotype, but you go deeper. You either go in for a whole exome or a microarray in consultation with your geneticist. On the recurrence risk, if the cleft is isolated, if 5%, if one sibling, so if a previous sibling has a cleft and the couple come to you that, look, I'm very worried, my previous child had a cleft lip. Now, please tell me if the present baby has it or not. The risk is only 5% above the age risk. If a parent is affected, even then it's 5%. And if two siblings or both the parents are affected, then it is 10%. The recurrence risk for syndromes can be autosomal dominant, recessive, X-linked, dominant or recessive, depending upon the syndromes associated. So there is Treacher-Collins, there is Perry-Robbins, there are more than 400 genetic syndromes, as FMF puts it, that can be associated with cleft lip and palate. It's not so simple, but our job antenatally is to segregate isolated clefts from complex ones, because how much ever well you treat the complex ones, the outcome may not be very good, and therefore our job antenatally is to make sure that the clefts are isolated, that the microarray is normal, and this is where the role of antenatal diagnosis and counseling takes place. I would just want to touch, since we have a lot of obstetricians listening here, I would want to touch upon this fact where there are a lot of times there is, I can stop sharing so that we could have. So a lot of times, Dr. Sujit would agree, we get calls saying that it's a young primary gravida, NT scan normal tha, double marker theek aaya, everything was fine, and now suddenly there is a cleft lip isolated. The couple was recently married. This is an unplanned pregnancy. There is also some pilectasis randomly somewhere, and the couple is absolutely not ready to take any risk for this facial cleft diagnosed. Now, I don't want to put across a wrong message that this pregnancy could be terminated, but our job as clinicians and care providers is to give a balanced counseling, a non-directive counseling where you tell the pros and cons. So you tell the couple the pros and cons of this pilectasis along with this cleft lip and palate. And if they choose that they do not wish to continue this pregnancy, then is it possible legally? Yes, it is possible legally, but the indication for MTP here would not be fetal because this is not a lethal anomaly. This pregnancy is being terminated because of the fear of an evolving genetic or a syndromic condition where the couple do not wish to take all this risk. And although our laws have extended to 24 weeks, what beyond 24 weeks? What if something comes up at 30 weeks or after birth and they do not want to risk it essentially because it's their first baby and it's an unplanned pregnancy or whatever their social reasons may be? Yes, they do have a right to go ahead and discontinue the pregnancy, but please work up this fetus, because if in next pregnancy she again comes back to you asking, what is my recurrence risk this time? You may not have an answer if you don't have the genetics of the previous baby that was terminated. So the ideal situation is to have a unilateral cleft lip, everything else ruled out. You do an amniocentesis, the microarray is normal. You pick up the phone, you call the smile train, you connect the couple with the right people. The couple has an online consultation with Dr. Krishnamurthy sir, with various other resources like the speech therapist, the feeding specialist, the neonatologist, and then the couple makes an informed decision, because after talking to everybody, especially in an uncomplicated unilateral cleft, most couples, if not all, would want to continue the pregnancy. The situation is completely different for a complex facial cleft where the decision should really be left to the couple. So this is all from me and I'm open to all questions. Thank you so much for the opportunity.
Yeah, that has been very excellent, informative talk about this prenatal diagnosis. You are next to Dr. Lakshmi in India regarding this imaging about cleft lip and cleft palate. Very excellently explained, and part of counseling, which is very, very important, which is mostly neglected by our obstetricians, that you highlighted. That is very important thing. An important thing I want to highlight here is about isolated cleft palate. The equal to sign of uvula, that should be part and parcel of your routine screening for each and every patient. So many of us don't look at that, but it is very easy to pick up that thing also. If you don't get that, take an extended view of the neck to look at the whole palate with good amount of liquor in the oropharynx. So excellent talk from Dr. Pooja. Congratulations.
Thank you so much, Dr. Sujit. I think the fact that prenatal diagnosis was the second talk after the management, that speaks volumes about the scenario in India.
Yeah,
that
right.
there are a lot of children they are waiting to get operated by a smile train and Dr. Krishnamurthy sir's team. And there is still a lot of clefts being missed antenatally, and we need to be more aggressive towards diagnosis so that a lot of this chaotic discussion happens antenatally rather than everything rushing around postnatally.
Still, there is a mentality of many parents to terminate the pregnancy once they are told about these things. So, in your OPD, in your OPD area, pre-surgery and post-surgery photograph should be stuck to show all things to the patients and relatives and parents. That will
Definitely.
create huge impact.
Yes.
Any questions? I don't see any questions here. Harsha, any questions are there?
Yes, sir. One question is there. I'm sharing on the chat. Yeah. 1 second, sir. There's a question. Can stem cells be used to improve palate repair, both primary and secondary?
Stem cells.
Yes, stem cells, STEM.
I think it's for Dr. Krishnamurthy, sir.
Yeah, thank you. So I don't think we have any evidence to suggest that stem cells have a role in the management of cleft lip and palate. We have started using platelet-rich plasma, which has some growth factors, particularly to grow some bone in the alveolar cleft. But beyond that, tissue engineering has currently no role to play. But there might be immense possibilities of that as research progresses. But as of now, we don't have any known role for stem cells.
So, sir, do we give PRP as a routine for everyone, or is there a case exception?
So when you are doing the bone grafting, so there is something called as BMP that's available today, bone morphogenetic protein, that's commercially available. Unfortunately, it's not still known whether it's safe in children, so we don't use that. But this is something which can be used instead of taking a autogenous bone graft. So PRP is something that helps in additional quality of bone formation. So it's often used along with the bone grafts right now, like it is used for many things, including, the hair and wherever else. Yeah. It has a lot of growth factors in it, which help in regeneration. Yeah.
There's another question from Dr. Anjum Sheikh. What is the best treatment for otitis media with effusion glue ear in individuals with a cleft of the lip or palate?
Yeah, thank you. I will take that. So this can be a common problem of otitis media with glue ear. So basically, what happens is the drainage from the middle ear is not adequate or is appropriate, and then the secretions as a result of this otitis or the inflammation gets thickened and gives rise to this glue ear. Sometimes initially when you find secretory otitis media, the management is just medical in terms of relieving of symptoms or antibiotics. But if you get into a situation where there is thickened secretions and it is not draining, the ENT will then make a small little tympanostomy or a small little hole in the tympanic membrane and put in a very fine drainage tube there so as to allow for the secretions to come out. This tube is commonly referred to as the grommet. And if this problem has been there before the time of cleft palate repair, we would insert this grommet at the time of cleft palate surgery. These drainage tubes then get spontaneously extruded out over a period of time, and hopefully the problem is sorted out by then. Sometimes this can develop even much later, number of years, even after cleft palate repair is done. And once again, it would require an assessment and probably a grommet insertion. A failure to take care of this problem, and if it gives rise to a chronic status, then you can have destructive changes, including tympanic membrane perforation, resultant partial deafness, etc. Yeah, this is something that we should be aware of and then look for signs and symptoms in the child and take appropriate action. There are some parts of the world where prophylactically these grommets are inserted for every child with a cleft palate, but it is not a practice in our country. We don't think that is essential, but then the onus is on us to look for signs and symptoms, refer it to the ENT, and take care of this problem if it occurs.
Okay, thank you, Dr. Krishnamurthy.
Thank
Sir.
you.
Yeah.
Thank you, sir. Thank you, sir.
There's one last question I need to ask from this doctor, Dr. Arunima Ghosh. She's asking, what is the impact of having a baby born with a cleft of the lip or palate on maternal-child attachment?
Right. This is, shall I answer this one? This is a very, very difficult question to answer, but now I have about 25 years of experience treating, seeing thousands of children. I don't think there is any difference between the mother-child attachment, whether the child, I have not seen even a single instance, but there are problems with fathers often. Okay, so sometimes the fathers are extremely disappointed, and then they can kind of, overtly reject the child and the mother. It's a very significant problem, particularly in the lower socioeconomic strata, where the support is completely withdrawn, is lacking from the dad. This happens once in a while, but as far as mother to child bonding, I don't know whether there are studies done on this comparing with non-cleft children, but my experience over so many years is that there is absolutely no difference. But fathers can do with a little bit more of education. Not always, but sometimes. Yeah.
Okay, got it, sir. Thank you. Thank you for your words. And thank you, Dr. Pooja Lodha, for having a great session today. And thank you, Dr. Krishnamurthy.
Thank you very much for having me here.
Yeah. Thank you so
Thank you.
much, everyone.
Thanks a lot. Take care. Bye-bye.